difference between impotence and infertility then, Dr. Majo? Thanks for that brilliant definition. Dr. Majo, can you hear me?
Yes, what was the question?
I said, what is the difference then between impotence and infertility, please? Thank you.
So infertility is the ability not to get pregnant. Now, impotence, since we have a urologist here, will probably be more likely to answer that question. And typically with impotence, the man is unable to sustain an erection. So that is the definition of impotence.
So I think, Dr. Che, can you put some meat on it?
Yeah. Thank you very much. Well, we say that impotence is what the layman generally will use. We use the word erectile dysfunction. Erectile dysfunction is helpful for us because it gives us opportunity of looking at gradations of it and opportunities to intervene at one point in time. If you use the word impotence, it means that the die is cast, it is all over. And so we don't like that at all. So we call it erectile dysfunction. But as he explained, you are not able to have the erections strong enough for vaginal penetration. And so we call that erectile dysfunction. So we prefer erectile dysfunction. But impotence means that then we've come to a point that we realize that with all our interventions, it's not going to work. Then we say this is impotent. Thank you.
Okay, thank you. So we'll move on to Professor Tuli. What about a scenario where a woman is able to get pregnant, but then keeps losing the pregnancy? So we know there are women who have kind of multiple miscarriages. Would that be considered as infertility as well?
Thank you for that question. But the answer will be no. So I know that for a woman, for a couple, when they're struggling with the ability to have children, the end result of infertility and recurrent pregnancy loss may be the same. There may be some relationship in terms of some of the causes and even some of the treatments. But while infertility is the inability to conceive, recurrent pregnancy loss is the inability to carry the pregnancy to viability and delivery. Now, miscarriages are quite common in normal pregnancy, in normal pregnancy in humans. In fact, the statistics will suggest that the majority of women will have at least one miscarriage in their lifetime. Sometimes they don't even know they're pregnant. It may be a delayed period, and then they bleed heavily, and indeed it was a miscarriage. But we define recurrent pregnancy loss as a woman who gets pregnant and loses the pregnancy multiple times. It is classically defined as about 3 miscarriages. These days, we temper that definition a little bit, and we may begin a workup or even treatment for fewer losses. But classically, repeated miscarriages will be when you get pregnant and lose the pregnancy multiple times, classically defined as 3 times or more.
Thanks, Prof. Tuli. Dr. Antony, so how common is infertility then among couples?
Well, thank you very much. So infertility is fairly common. I mean, traditionally, we think that 10 out of couples who have been trying to conceive within a year will have some difficulty in conceiving. However, this does not cut across board because there are differences based on the geographical area that the couple are living in and the age, especially of the female partner. So traditionally, we say that it's about 10%, but as the female partner advances in age, this prevalence is higher than if you consider younger women. And again, like I mentioned earlier, the prevalence varies according to the geographical area. For instance, it's infertility said to be commoner in sub-Saharan Africa, typically West Africa is an example, and then the Middle East and the northern parts of Africa. In fact, some people have described the West African sub-region as the infertility sub-belt of the world because the rates here tend to be higher. Some authorities quote the figure to be in the 30% when it comes to infertility. In our country, Ghana, for instance, small studies were done in different pockets of the country, and averagely the prevalence rate will range from about 11% to about 25%. So I'll say that at least across board, about 10% of couples will have some challenge in achieving pregnancy within a year.
Thank you very much. So I'll move on to Dr. Majo. So if a couple is having difficulty in achieving pregnancy and carrying pregnancies to term, who is typically to blame? Is it an issue with the woman? Is it an issue with the man? Is it an issue with both? So typically, where is the problem stemming from?
Great question. So if a couple is facing infertility, we know that a third of the time the problem would be from the man. 30% of the time it can be from the man. 30% of the time it could be from the woman. And the other percentage is divided into, it could be both of them, or it could be none of them. There is something called unexplained infertility, and sometimes both the man and the woman are fine, and yet they're having problems conceiving. And so that is really the spectrum with infertility. It could be either, it could be both, it could be none.
So let me do a follow-up. So do you have an idea as to why anytime a couple is having problems with infertility, that especially in the African sub-region, they tend to blame the woman? Is there do you have an idea why it's so? Because it sounds like, you know, the man is as equally blamed for as the woman for infertility, and then the other percentage is, you know, both of them. And as you said, there is a percentage where it's unexplained because you can't find anything wrong with either of them. So do you kind of have an idea why people or families try to put pressure on the women?
I think, you know, that's another great question, but I think culturally in Africa that the woman has the responsibility of childbearing. So automatically they think the woman, if something is wrong, that it's definitely the woman. There are multiple reasons when a woman cannot have a baby, as opposed to usually one reason with the man is usually the sperm. So, and my colleagues can chime in, but typically I think it's just cultural that the woman has been blamed for not getting pregnant. But I'm not sure if there is any long-standing tradition as to why this is. So if any of my colleagues are able to shed more light on this, they're welcome to, but I'm not sure why our African communities are bent on blaming the woman for what the couple ordinarily can experience.
Dr. Majo, it's all right if I take you back a bit. So I'm just wondering, how long should one wait for to qualify, in quotes, as being infertile? How long should you have been trying for you to qualify to be, in quotes, qualified to be infertile or classified as infertile?
So like I said earlier, typically a year for if you're aged less than 35, and then over 35, about 6 months. Now, it's important to state that whenever a couple is trying to get pregnant, any month that the couple is trying to get pregnant, there's only a 20% success rate, which is called fecundability. So at the time, it's easy when everyone is getting pregnant around you to think that people get pregnant very easily, but it's only a 20% rate and a 20% chance. So that's important as far as putting perspective as to why we wait so long before determining whether their infertility does exist in this couple. So I think it's important for our viewers to understand waiting is just a process where we give you a chance, because every time you try, it's only 20%. And in the most optimal conditions, it's only a 20% success rate for every month a couple tries.
Wow, thank you. I think I feel so grateful now. Anyway, thank you. And Dr. Che, my question comes to you now. So what are the causes of infertility in male, or are there any risk factors that makes certain people more predisposed to being infertile or something like that?
Yeah, thank you very much. So first, probably I need to walk us through the whole process. Our objective as a man is to make the sperms and transport it out of the urethra or penis into the vagina for fertilization to take place. So if there's no fertilization, then the question is, at which point in this trip has there been a problem? So we can look at it from the fact that it may be because we are not making the sperms in the first place. So we call that formation. Now the sperms are quiet, or let's say the testes which make the sperms are quiet, I'll call it temperamental. It responds to so many things around you. So lifestyles, stress, it's quite sensitive. So anything that upsets you a bit affects the formation. The next one is the ability to concentrate the sperms to get the right quantity. Again, you may be making them, but you're not making the right quantity because the rate of production or some other factors that are supposed to help are not working well. Then the next one is the transportation. The tube. So you've got the valve difference that carries the sperms from the testes to the terminal vesicles and then out. So if any of these tubes is blocked, that can be an issue. Then of course also need an erect penis to be able to deposit it, in the female. So any of these routes and functions can be disrupted. Generally, we say that the formation is what has a much more debilitating effect. One thing about the testis is that it is based on hormones, which is testosterone and a few more hormones. Anytime the testosterone is not in optimum quantities, we have this problem taking place that the formation is not good. So somebody is obese, for example, somebody is not exercising, for example. These are things that can affect the overall hormonal environment of testosterone, and so the formation is not too good. We also said that it's temperamental. Any febrile illness, any viral infection, any sexually transmitted infection that affects the testis one way or the other, that can affect you making the formation. Then I'll just briefly through the tubes. The valves must be patent to allow the sperms to swim through. The sperms looking like a tadpole. So anything that affects the vas can be affected. Sometimes it's deliberate, vasectomy. So we virtually go and interrupt the tubing system, and the sperms cannot pass through. Sometimes it's due to surgeries and other factors that can occur. Sometimes even infections, gonorrhea and other chlamydia infections can block the tube, so the sperms cannot come out. Then, of course, we also talk about being able to deposit it. So the penis system must have a good integrity. The abnormality of the penis that can cause effect, and of course, also, erectile dysfunction as we talk about that can be. But I must end by saying that there are other issues such as I want to call it genetic, such that from right up initio, the ability to make sperms has been an issue, and this can run in families, and this can be due to sometimes other medications like radiation or some other chemotherapy that we have. So we look at the formation, look at the transport, and the ability to deposit. Any of these can be. So once we are assessing a male, we are asking ourselves a question: at which point is it difficult?
Thank you so much. Now that we've talked about the male causes, I'm going to move over to Professor Tuli. So how about the female? What are some risk factors and what are some of the causes of infertility that are related to the female?
Thank you very much. I really like how Dr. Che, the urologist, explained, what is normal and what can go wrong. And I will do the same for the female. And I would say, just like in most things, the female physiology is even more complex than the male physiology. So to start with, in order for pregnancy to occur, an egg must be released from the ovary. And that process depends on chemicals called hormones, which are released from the base of the brain. They come through the blood and stimulate the ovaries to start, to have the egg start developing, and ultimately, usually one or a few are ovulated. The fallopian tube, which is attached to the uterus, then holds onto these released eggs, and they travel through the fallopian tube. Often, fertilization occurs within the fallopian tubes, where the sperms that are deposited swim up, go into the fallopian tubes, and fertilize the egg. The fertilized ovum then makes its journey slowly down the ovaries, gets attached to the uterine wall, digs in, grows out, and continues to grow into a fetus and ultimately a baby. So multiple things can go wrong along this path. So let's start with the ovaries. As I already mentioned, we need to have the release of chemicals from the brain to result in to stimulate the ovaries to begin to produce those eggs. Conditions like stress, medical conditions like thyroid disease and hyperprolactinemia, which is another hormone which is produced from the brain in excessive amounts, result in that process of stimulation not occurring optimally. And then an important factor, risk factor there, is the patient's age, the woman's age. So unlike males who continue to produce sperms almost continuously throughout, from adolescence onwards, in the case of the female eggs begin to develop while the baby girl is still inside the mother's womb. They get to a certain point and they get arrested. They stay there dormant. And every month after the girl reaches puberty, a group of those cells begin to develop, and optimally one or a few get released. And this process repeats itself every month. There is no these cells are not replenished. So as a woman ages, the population of these cells decrease gradually, and there are some periods, such as with at 35 years of age, thereabout, or with menopause, when these levels decline precipitously. Therefore, the older a woman is, the fewer the number of cells that are available to begin the development and ultimately become mature eggs. So age and what is called ovarian reserve, the number of immature eggs that are waiting to develop, is an important consideration in the causes of infertility. Medications that we take. So for example, a woman gets treatment for cancer. Sometimes those cancer cells, those cancer medications can destroy some of those immature eggs and therefore reduce the chance that that woman will ultimately be able to ovulate. Once the egg is released, we then have tubal factors, things that make the tube not patent. So scarring from things like infection, gonorrhea, chlamydia, what is called PID, pelvic inflammatory disease. They can even be conditions that are outside of the reproductive system, such as someone has major surgery, has a ruptured appendix, causes scarring on the outside of the uterus, and that external pressure can result in the fallopian tubes not patent enough to allow either sperm or the fertilized egg to pass through. Now, once the embryo arrives in the endometrial cavity, there are factors there that could also increase the chance of the woman not getting pregnant. Last week, we talked about fibroids. In uncommon cases, there may be a fibroid that is laying right just under the lining of the uterus, or a fibroid that is actually hanging inside the endometrial cavity, preventing the normal implantation, the fertilized egg attaching to the uterine wall and resulting in pregnancy. Going down to the cervix. The cervix is a channel through which the sperms will come up in the first place. So there could be scarring of that cervix, which makes it narrow and prevents the sperm from coming up. There are other what we call congenital things that can happen. There are rare conditions where a woman doesn't even have a normal uterus. Either it's completely absent or it may be malformed, and all of that could affect the ability to get pregnant. So just to summarize, there's a complex series of events starting from the brain to the ovary, to the fallopian tube, to the cervix, to the uterus, which all have to line up well for fertility and pregnancy to occur. And multiple things can affect these segments or compartments of fertility and result in a woman being unable to conceive.
So thank you for this very detailed explanation. So you talked about infections and PID, for example. Now, what about like induced abortion? So some people, when they are younger, they get pregnant and they go for abortions maybe several times. And then when they are actually married, they have difficulty having children. So how does induced abortions kind of affect fertility?
So let me start off by saying that, abortion or termination, which is done by a professional in the normal sterile fashion, is overall a very safe procedure. I think the major problem with abortion and infertility comes with the unsafe abortions. So people who go to unqualified people who may not use sterile instruments, resulting in an infection that may happen, and therefore most commonly result in scarring of those fallopian tubes we talked about, which may then result in the patient unable to conceive subsequently. There are other things that could happen. So, for example, in most cases of an abortion, the cervix has to be dilated in order to have the products of conception evacuate. So if that is not done properly, and there are lacerations on the cervix, for example, or infection in the cervix can get scarred, preventing sperm from going up. Or if it gets lacerated, the woman may get pregnant but have what we call pregnancy loss because the cervix is now insufficient or incompetent to carry that pregnancy to full term. So abortion as a medical procedure done well by a professional, generally safe. Women should generally avoid those unsafe abortions by people who are not professionals. I know there's also a psychological or mental component. As you can imagine, if somebody has an abortion and then gets married and then they are not getting pregnant, it is easy for one to blame oneself for what happened. And remember, those stresses are not helpful in the process that I described in terms of being able to ovulate and so on. So avoid unsafe abortions. And as I said, even after an abortion, most women can still get pregnant and conceive. And most importantly, if you're having difficulty, see a professional, as we'll describe later on in this talk, for help, for evaluation to find out what may be the problem. It may or may not have anything to do with the abortion that you had.
Beautiful. Thanks, Prof. Tuli. So usually, there's this debate of once saved, forever saved. Now, in terms of fertility, Dr. Ntumi, if you've been fertile before or if you've had a child before, does that mean that you are always going to be fertile? Or let me put it this way. Sometimes you hear of couples who've had a baby and after 21 years, maybe even 10 years, they are still trying and they can't have a baby. Is there anything like that? Is fertility permanent?
All right. So thank you very much. So clearly, from what we see, it's obvious that fertility cannot be permanent. Fertility changes with time. I mean, Prof. Tuli, in telling us about the causes of fertility, for infertility, for instance, mentioned that age for women is an important factor to consider. And so once we age, it clearly shows that our fertility will not be as it was when we were younger. So as we age, fertility will decline. He mentioned clearly that for women, the pool of eggs that we have in our ovaries begin to decline. And so as we age, we'll get to a point where we may not have quality eggs to release, and that will affect fertility. The other thing also is that as women age, there's opportunity for all the other factors that he mentioned, like the patency of the genital tract, for instance, to get affected. You may have an infection that may end up scarring or blocking the tubes. Women may develop, last week we talked about fibroids, and we mentioned that some fibroids, based on where they are located, for instance, may affect fertility. So if you have a fibroid that is encroaching in the cavity of the womb, for instance, that may affect fertility, when this may not occur when you are much younger. And then also the stresses of life as women age may affect their chance of getting pregnant. I mean, once they are older and get delayed pregnancy, and once they get pregnant, the pregnancy is not coming, they become very anxious, and then they get into a cycle of stress and depression, and all these would affect their chances of getting pregnant. And so fertility is not permanent, it declines. Indeed, in West Africa, there is a syndrome we call the second baby syndrome. Simply means that this couple would have had the first child easily, and then now begin to have difficulty in getting the second child. And usually it's because of stress or sometimes scarring that occurs because of infection. If the previous pregnancy was not managed properly and they develop some infection after pregnancy. So clearly, fertility is not permanent. It may change and declines as we age.
Thank you, Maud. Yeah, I think Dr. Antony has looked at it from the perspective of the female. I also want to say that from the perspective of the male, fertility is not constant either. One of the most common causes of secondary fertility in the male is what you call varicocele, where you have got distended veins in the scrotum, warming up the scrotum more than normally is allowed. God in his own wisdom has kept the scrotum outside the body. And so the temperature is a bit lower than that of the body and keep the sperms alive. Anytime the temperature gets higher, then makes it difficult for the sperms to survive that heat, therefore they die off. So a man can make a woman pregnant, but like Dr. Antony said, as issues come up, that can be a problem. So the varicocele or development of these veins, which comes with sometimes congenital, sometimes with exercise, sometimes with weightlifting and other issues, can come in. People adopt new lifestyles, smoking, alcohol, and other factors because they are now prosperous, and that can be an issue. Medications. We talk about the sperm being able to move and transport. Some of medications, like the antihypertensives, especially the calcium channel blockers, can be an issue, making the sperm not be able to move as much as we can. Sometimes surgeries, hernia surgeries in the pelvis, which come up as one goes on with the activities and life, can be an issue. So just like in the female, male fertility is also not that constant. Issues come up, it can affect getting fertility. Thank you.
Okay, so maybe before I go on to the next question, there's a little follow up maybe to Dr. and to me. So these days, like in the past, you would see like women did not really go to school, right? So maybe when they finish their secondary school, they'll get married and then start having children. Now we have, women kind of going on to do first degree, master's, PhD, sometimes even before they start having children. That's delaying having children have a negative effect on fertility. So to rephrase, if someone kind of waits till they are done with all their PhD and everything, does that affect the ability to have children?
Well, thank you very much, Dr. Lai. So clearly, the PhD does not affect their fertility. Certainly not. But because they are waiting, age catches up with them. And like Prof. Tuli said clearly, age is a significant factor to consider when it comes to female fertility. So while the weight and age, then it's possible that at the time they are ready to conceive, they may not be able to have, quality foods. I had a wonderful mentor who told me that if he became a president, he would decree that after secondary school, women should have a national service of pregnancy, where you deliver one child and then go on to university, so that you have that at the bank. That's clearly because we see a lot of young women who might have been fertile when they were younger, and then in their late 30s and early 40s now are ready to conceive. They have everything they want and they can't because of age, and then the other factors that I mentioned earlier, infections, diseases, uterine masses, and all the other things that may affect the ovarian function, hormonal changes. So all these factors add up, and then they may not be as fertile as they would have been if they were younger.
So let me chip in a little here. So obviously, the decision on when to have children is a complex process, depending on multiple factors. A few things I will say though are that while we advance through education or whatever the case may be, I think we should at least have a thought about the implications of delaying